Hi, my name is Vinay Prasad. I'm Chief Fellow in Medical Oncology at the National Cancer Institute and the National Institutes of Health in Bethesda, Maryland. I'm here today to discuss our article, A Decade of Reversal, an analysis of 146 contradicted medical practices. I'd like to also thank my co-authors, Dr. Andre Vandross, Caitlin Toomey, Michael Chung, Jason Rowe, Stephen Quinn, Jacob Chaco, Durga Borkar, Victor Gall, Senthil Selvaraj, Nancy Ho, and a special thanks to Dr. Adam Sifu, with whom I've done prior work and much of the work on medical reversal with. I'd like to also thank Dr. John Ioannidis, who has been a leader in this field, of course, and who's done some key work with us on medical reversal. This work represents our attempt to estimate what proportion of standard of care or current medical practice is incorrect, what percent of things we're doing right now that we're getting wrong. In order to do this work, we performed a one-year survey of all articles that appeared under the heading Original Articles in the New England Journal of Medicine. This was 2,044 articles which we reviewed. Two reviewers independently analyzed all the data for these articles and then compared results afterwards. Of all those 2,000 articles, what percent assess a medical practice, something we're currently doing, whether that be a screening test, a diagnostic test, a medication, a procedure, or surgery? We found that about two-thirds of them, or 1,344 articles, assessed a medical practice. Our next question was, of that 1,300 articles, what percent tested an established standard of care? We found that to be 363 articles, or just about a quarter of those. And then we asked, of those 363 articles which test current standard of care, what percent of those conclude that the standard of care is correct, or as we call, reaffirmation? What percent conclude that standard of care is incorrect, or what we call medical reversals? And we found that it was really split. About 146 or 46% of articles contradict current medical practice, and about an equal number, 138 or 38%, validate medical practice. So for original articles in the New England Journal that test established standard of care, about half contradicted and about half validated. The remainder, about 20%, were inconclusive. They could neither render a firm verdict either for the merits or the harms of the intervention. So what are the implications of this work? Quite simply, what we're posing here is we're asking, and this sort of dovetails with previous investigations done by the British Medical Journal and a project called Clinical Evidence, where they have surveyed a broad collection of medical practices, something like 3,000 practices, and they found about half of those actually have an unknown evidence base, that they're neither based on good evidence nor have they been disproven. And what our work adds is it suggests that of all those things we're doing currently that lack good evidence, probably about half of them are incorrect. What do the results of our study mean for patients? Well, patients who are embarking upon procedures, screening tests, diagnostic tests, should really try to ascertain whether or not those tests are based on good evidence. And by good evidence, I mean randomized controlled trials powered for hard endpoints, such as mortality or morbidity, and not surrogate endpoints. Many of the reversals that we've examined were actually propagated based on faulty surrogate data, which was ultimately overturned by studies examining hard endpoints. So patients who don't want to take part in practices that may someday be reversed should really scrutinize practices and look for the best evidence for the practices that they are about to take part in. The consequences of medical reversal are quite dire. It really implies harm to three people. First, all the people who were subject to the intervention during the years it fell in favor. Now, those are people who, in retrospect, we realize received no benefits and received harms of their procedure or intervention, screening, or diagnostic test. The second way medical reversal harms patients are the continuing harms of reversal. Medical practices have an inertia to them, and other work by leading researchers such as John Ioannidis has shown that it takes about a decade before contradicted medical practices fall out of favor in the medical literature. So during that contradiction period, that extra decade, these practices continue and further patients are harmed by medical practices that are ultimately detrimental. And the third way the medical system is harmed by medical reversal is loss of trust in the system. Now, patients expect that the doctor's recommendation has been validated based on evidence, that it's better than what came before and that it will be improved upon in the future. But medical reversal suggests that these are practices that should never have been instituted. They were instituted in error. Looking through our article, you'll see that there are 146 practices. We have provided a supplementary appendix where we detailed every one of them. We make a case for why these were standard of care, why they in fact fell in favor, and ultimately why they were overturned. What was the evidence that overturned them? And you'll see that for the vast majority, it's hard to dispute that these are in fact medical reversals, that the totality of the evidence suggests that they are in fact deleterious. You'll see things like autologous stem cell transplant for metastatic breast cancer, which has progressed through multiple lines of therapy. You'll see medical reversals even for things that make perfect sense, that for patients who have allergies to dust mites, providing impermeable covers on bedding would actually decrease the rate of those allergies. That was a $26 million a year industry that was contradicted by a set of papers in the New England Journal of Medicine. You'll see common things such as the AFFIRM study, which contradicted primary rhythm control strategy for atrial fibrillation. And we've tried to provide a table of 10 key reversals in the manuscript itself. But for interested parties, we've provided a full listing of the 146 medical reversals. The takeaway message of our paper is that a large proportion of the medical practices which are based on little to no evidence are probably incorrect. Their continued use jeopardizes patient health and wastes limited healthcare resources. We should work towards identifying these medical practices of which the data is not robust and subject them to systematic appraisal, ideally with large, well-done, randomized controlled trials powered for hard endpoints and conducted by non-conflicted bodies. Thank you for the time.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.